Okay, so today's talk will be on critical appraisal, step 3 in the EBP process. You can see here that we've already come up with a clinical question, step 1. We've searched evidence on databases or Google and found something that we think is important. And then the third step is to critically appraise that evidence. So what EBP's done is give us tools to make this process more efficient and give us confidence in making a critical appraisal. In other words, discarding some evidence that looks good, yet we shouldn't pay attention to it, or weighing things that are more complex for us as important. And those tools include hierarchies of evidence, worksheets, something called a systematic review, and critical practice guidelines. So our talk today focuses on hierarchies of evidence. So this is the hierarchy of evidence. We can see it's pretty complex. It includes several different levels. We can see the levels here on the far left, pretty small. They go from 1A to 5. Then we can see different categories. And here we can see this first category is titled therapy, prevention, and there's several different criteria under each level: prognosis, diagnosis, differential diagnosis, symptom prevalence, and economic decision making. What we're going to do is focus just on the therapy, prevention, and etiology column. Here's a close-up of that, and now we can see the levels more clearly. And we can see that there's still a lot of information here that's a little bit overwhelming. But if we break this down to its core elements, it starts to get a little easier. And we can start to notice is that now with all of the other detail removed, there's some core issues that remain in determining what's at a different level. And we can see first, we see this 1B, which is almost the highest level, higher being 1A, is RCT. And we notice that 1A is really a systematic review of RCTs. So systematic review is really a collection or several RCTs. So basically we know what an RCT is, we know what both a 1A and a 1B are. And we notice the same thing for level 2. So we have level 2A, level 2B, and we notice that a cohort study is essentially the key for level 2 studies, and that a 2A is just a collection or systematic review of cohort studies. And then finally, if we go down, we notice that 4 is a case series, and 5 is expert opinion. So if we understand what an RCT is, a cohort study is, and a case series, an expert opinion, we can get level 1s, level 2s, level 4s, and level 5s, and we'll leave out level 3 for right now. So essentially, this is a diagram of a level 1 study, which is called a randomized controlled trial. So let's look at the key elements of a level 1 study and why it's considered such a high level of evidence. So essentially, with a randomized controlled trial, we have an eligible set of patients. They're screened to enter the study, and essentially they're then randomized either to a treatment, intervention, or exposure group, and then to a control group. And the key is we're going to make a comparison at the end of the study whether or not the treatment or exposure does better than the control on some outcome or dependent variable. So essentially we'll have a pre-test and a post-test. And if you recall in the PICO format, we have the patients have some kind of characteristics. The intervention or exposure is the I. The C is the control, and then the outcome is the variable that's used to determine if the intervention has an effect, which we are going to get a pre-test and then a post-test. Now, one of the things that's interesting is the importance of the randomization. And the randomization really is important for controlling both known and unknown confounding factors that might influence the intervention and control groups in ways that we don't understand. And that's the importance of the randomized controlled trial and while it's weighted as the level 1 evidence. Here's an example. We have patients with diabetes mellitus with tight Achilles tendons, and the relevance of this project is what we know that people with diabetes mellitus develop plantar ulcers, and once they do, it's difficult to stop those ulcers from progressing or allowing them to heal, and then oftentimes it results in amputation or limb amputation. So it's relatively important to stop those ulcers. So one approach at stopping those ulcers has been to try to improve the length of the tendo Achilles or dorsiflexion motion. And so there are two interventions that were under investigation. One was lengthening with surgery, which is our eye in this case, and the other is a total contact cast, which is our C in this particular example. And so the randomization achieves equivalence of groups on known and unknown variables. So known factors might be with whether they've had an ulcer in the past or not, and unknown variables might be things like how their skin health influences the ulcer development and things like that that we can't measure or don't have a way of determining. Okay, and so essentially these, we do a pre-test in this case on dorsiflexion range of motion in both groups. And what we notice is that pre to post, afterward, the tendo Achilles lengthening group has a greater dorsiflexion than 11 degrees. The total contact cast has less than that. And so the better treatment relative to dorsiflexion range of motion is tendo Achilles lengthening. This is an example of a randomized controlled trial where the O that's being used is more theoretical than patient-oriented. A better outcome variable in this case, in terms of our PICO question, might be ulcer development or something like that. So that would be a level 1 study, and let's contrast that study with a level 2 cohort study. And what we can see here is that we have the same exact kind of diagram of the study design. So this is a prospective study that's looking forward in time. And most of the elements of the RCT are represented. We have eligible patients, we have an I and a C, and then we have an outcome variable that's measured pre and post. So the only difference is that the patients aren't assigned randomly to the intervention or the control group. And so essentially the cohort study is identical to the randomized controlled trial except for the randomization. So here's a good example of that. I have the same kind of study design here with a study that was performed on whether a PEP program, that's a program enhanced performance to prevent ACL ruptures, is effective compared to regular training. So the I is an intervention program meant to prevent ACL injury, and the control is just regular training and the preseason as you work up for soccer. And so this sample was high school sports teams, in particular women's sports teams that, and the sports teams themselves were soccer. And so what they did is they went out to the community in Los Angeles and asked high schools and colleges to adopt the program. And those that adopted the program were put into the intervention group, and those that didn't adopt the program were put into the regular training group. So obviously the assignment or the adaptation of the program was not random. It was pre-planned or based on other factors. And so essentially this is a great example of a cohort study. And then none of the people had tears before the program started, and what they did is their dependent variable in this case was the number of tears per player. So there were 2 tears per 1,000 player in the PEP program group, and there were 32 tears per 2,000 players in the regular training group. We can see that the rate of ACL injury is much higher in the control group than the prevention training group, and so the decision is that in this particular example, the PEP program was effective at reducing ACL injury in high school athletes. So now we're going to drop down from a level 2 and contrast that with a level 4 case series study. And this you can see essentially is one arm of a randomized controlled trial. So, and usually it's the intervention arm. So we have a set of eligible patients. They're tested before treatment and then after treatment, and their improvements in outcome are noted. And it's clearly obvious in this example that there is no control or comparison group. So you have no control over things like natural history or tendency for the patients to recover on their own or mature in the case of pediatric patients. And so it's a fairly weak study design. So given that, what is it used for? Well, the key thing it's used for is to introduce a new treatment and help plan for something like an RCT. So some examples of that might be like a new intervention related to stroke care. So recently there's been the development of constraint-induced therapy. Well, constraint-induced therapy for stroke patients means what you do is you disallow the person to use their unaffected arm and force them to use their affected arm. And by doing this, you basically assure more use of their affected arm, and then they get better. But at the same time, it seems kind of extreme because of the difficulty you're causing the patient to go through in using their affected arm. So something like that, you might start with a case series to understand that it does have an effect. And then after you've established that it has an effect, you might go back then and do an RCT to compare it to a control group and see if it exceeds the natural recovery that would occur usually with that problem or disease. And then here's another example. So this is an example related to orthopedics, where we have patients with posterior tibial tendon dysfunction, which is a fairly rare kind of problem that patients have in their medial side of their ankle. And the treatment would be a lateral column lengthening with transfer of the FDL tendon. So fairly aggressive treatment, and so relatively new and involved. And so you would want some example of a outcome that's fairly convincing before you were going to do something as aggressive as this. And so basically there's studies that have looked at both foot posture using radiographs, walking distance, and then a functional scale that's patient-oriented or self-report scores that they improve on all these variables. And so that would be a good example of a case series study where it shows a fairly aggressive novel treatment and how it affects patient outcomes. So in summary, what we've done is taken a fairly complex column of the evidence-based hierarchy, the therapy, prevention, and harm column, and reduced it into essentially three different focuses. The randomized controlled trial, which is a 1B ranking, the cohort study, which is a 2B ranking, and a case series, which is a 4 ranking. An expert opinion should be relatively obvious to you.